I'm going to tell you a story about some innovative work that's taken place at the Royal Manchester Children's Hospital. First, let me introduce myself. My name's Julie Jolly and I'm a matron for service improvements at the Children's Hospital. I'm a registered children's nurse and very proud to be so, but my role is quite diverse. For those who don't know anything about the Royal Manchester Children's Hospital, we're one of the largest hospitals in the UK. And these are just some of the facts around the Royal Manchester Children's Hospital. So we see over 40,000 admissions a year. We employ 167 consultants, over 900 nurses, and we attract close to 48,000 attendances via our paediatric emergency department. So we are a very, very busy hospital. And these figures are based on the 14-15 stats for the hospital, so you can probably add a couple of thousand onto them with the increased workload that's come through recently. We have 25 specialist services within our hospital as well. And if you consider that these are all children, children come with their own problems, their own stipulations and their own ways of doing things. And the impact that that can have around infection control can be massive and very, very difficult to manage. So now I'm going to tell you a little story about what happens in the Royal Manchester Children's Hospital, and we're going to go back to 2013. And in 2013, as part of my role, I was asked to look at creating some working partnerships with other hospitals. At the time, my brother lived in San Francisco and he used to travel quite a lot there. His in-laws, they lived in a place called Fresno, and we used to travel there quite often as well. And during the trip across there, we used to go past this strange-looking building. Reminded me of Little Princess House, all pink and blue. Looks a bit like Legoland. Eventually, I asked them what the building was, and they told me it was a children's hospital. So on returning to the UK, I looked up this hospital, contacted them, found out that they worked very similarly. They had the same sort of numbers that we did, same specialties, etc., etc. So I made contact with them and arranged to do some work with them to see if we could do some shared practice. I then arranged a trip. I was going to see my brother, so I joined onto that. Arranged a trip to go and see the hospital itself and went into this little toyland. Beautiful hospital. It was near enough the same age as ours. I think it was a year older in its build. Had a good look round, got introduced to some people there, and over the next couple of years we did some work together to create a working partnership so that we could do some networking. And then in 2005, I actually flew over there to do a fortnight's work with them, looking at their practices, seeing what we could share. Some of the things that we saw over there were absolutely fantastic. Some of them were quite behind what we'd done already. But there was things that we could share with them and what they could share with us. And it was during this time that they actually introduced us to one of the things that they did. And the main purpose of us going over there, as I said before, was around clinical practice. We wanted to see what clinical practice they did that we could perhaps bring back to the UK. We wanted to see what innovations they had over there and could we bring them back to the UK, but also to show the innovations that we did and to share them with them. We wanted to see their IT solutions. We had this image that America was far, far, far further ahead than we were with electronic patient records and things. But I can assure you they're not. We wanted to see what education programs they had, to see whether we could actually learn anything from them that we could perhaps bring here and improve the education of our clinical staff. Wanted to look at their leadership skills, how they use their leadership and their management skills. And again, we shared our leadership and management tools that we had over here in the UK. Basically, we wanted to make improvements, whether that was clinical, from the patient journey, or whether it was clinical from a way of using a particular resource that was available. But most of all, we wanted to look at improving the quality of our patient pathways and the care that we gave. So as we said, many areas were shared. Lots of things were good and some things weren't so good. But one of the things that we did see while we was there was this thing that they called Wally. So Wally, when they rolled it out, looked like a little robot out of Star Wars. It was, in fact, a UVC robot. And on a discharge of a patient, they rolled this little machine out, its little head popped out of it, and it started spinning round, and this blue light was flashing around. And they explained to us that this was UVC. They used it to disinfect a patient's room on discharge. So we was really interested in this. We returned to the UK. many months later, I was doing some work within our own hospital, and basically every specialty in the hospital was asked to look at their specialty, see what improvements could be made, and they set about doing a whole project plan around it. I work quite closely with our oncology unit. One of the biggest problems in the areas of improvement that they needed was around infection control. These children are some of the most vulnerable children around where infections are concerned because of the conditions that they have. And prior to starting this project work, they'd actually had some children who had contracted VRE and CPE as inpatients. And as part of their condition, they deteriorated quite quickly and they'd actually died. Nobody comes to work to do any harm to the patient, and to think that a patient has come into hospital, unwell obviously, but they've actually not left the hospital the way you would expect them to because of something they've picked up on your ward area, that can be quite devastating for not just the nursing staff but the clinicians that look after the patients. And that's where this group of clinicians, nurses and specialties, that's where they were at the time. They wanted to see what they could do, and that was the main thing that they wanted to concentrate, because they felt that was the biggest improvement they could possibly make within their service, was to make the environment a safer place for the children. They've done lots of work around giving patient information out to the parents. As I said earlier, children come with their own problems. One of them is we don't just look after the child, we look after the whole family. Mum, dad, nan, granddad, brother, sister, auntie, uncle. No restrictions on visiting. You know, everyone gets 24-hour access virtually. Children in themselves don't like washing their hands. You know, parents, they're in hospital, they become very hospitalised. Things that you might do at home, you don't necessarily do in hospital. So it can be very, very difficult to keep and monitor what's going on. So when they decided they wanted to look at what they could do, I suggested that we looked at different techniques. We'd already looked at re-educating the families, we'd looked at redoing our information leaflets, we'd looked at trying to minimise the contact that came onto the ward. So we decided, yes, we'd have a look, see what was out there in the UK around UVC and see if we could actually improve our infection control rates within this unit. We did a literature search to start off with. There was virtually nothing in the UK that had been done in the UK on UVC. Loads done in the USA. And most of the research that was out there was basically saying the same. They highlighted the issues with UVC around shadowing and around the different types of machines that were out there. There was 2 studies done here in the UK, but they were done in a new hospital setting that was about to open, so there'd never been any patients in there. So the data that they collected wasn't necessarily the data we wanted to see. We also rang quite a few companies in the UK, found it very, very difficult to find somewhere that actually had a machine that was actually functionable. Lots of them had prototypes or, yes, we're currently manufacturing, but none of them actually had any systems available. Eventually we did find a system. So the company came in, talked us through it, told us, you know, what their system was available for, what its capabilities were. And between the two of us, we managed to come to an agreement that we could do a pilot study. So we started the pilot study and we just concentrated on the oncology unit. Our oncology unit is a 22-bedded ward, a large outpatients department and a bone marrow transplant unit as well, with another 8 beds. So it was quite a vast area that we were going to do the pilot on. And as you can see on the charts on the wall, the first chart shows the number of infections that we had prior to starting the pilot study. And they varied from CPEs to VREs and MRSAs. And as you can see, some of them were quite prolific at the time, particularly VRE, which is what the staff had said was a big problem for them. We started the pilot using the Surfacide UVC machines. And the difference with these machines we found was that it comes with 3 towers instead of a single tower. So you set them up in a room once and you can do the whole room, including an ensuite bathroom, all in at once. So it wasn't as time consuming as we thought. Because it was a pilot, the nursing staff actually decided they were going to lead on this, and they did it all. So we would do a basic soap and water wash of a room when the patient was discharged. Once it had dried down, we'd take the machines in, set them up, set them off. Basic room took around about between 20 and 40 minutes, depending how much equipment was in there. Because we leave the equipment in, it also, the light actually contacts all the equipment, so it disinfects the equipment as well. And we run the pilot for a number of months, and then we gathered the data so that we could do a comparison of the previous 9 months. And the second chart is actually what we found when we looked at the data again 9 months later and what had actually happened since we implemented it. And as you can see, there's quite a significant decrease in the number of infections that were actually being reported from the ward area. And when we actually looked at the facts and the figures, we'd ended up with around about a 43% decrease in the number of acquisitions that we'd had during the period of the pilot study. Now, you could argue that might be pure coincidence. You know, you could argue that it was the time of year. You could argue that the previous year to us doing the pilot study, it was a prevalent year for VRE and MRSA. There's lots and lots of arguments. However, what you can't argue is the fact that the staff on the ward, the patients and the parents that were coming into that ward, there was a general sense around the ward that they'd actually made a massive impact on that ward. We continued to use the machines, and over time we've now been using them for just coming up for 2 years. And in those 2 years, we would normally have expected, with our previous history, to have had around about 5 or 6 hospital-acquired infections per year on this within this particular area. We've had 1 in the last 2 years. Again, you may say that's coincidence, and it may well be. However, for those staff who at the start of this project were feeling as if they were actually doing harm to children through no fault of their own, their hand hygiene is really good. We have a very strict bare below elbow policy. We're very careful about who has contact with the children and, you know, etc., etc. But they actually felt that by the work that they had done, they'd actually made a massive, massive impact to their patient group, and they felt that they were actually doing their jobs again. We decided after the pilot study, because of the results that we had, that we wanted to take this a little bit further. But obviously we needed to work with our infection control team on this as well. And one of the things that they wanted was they wanted us to complete a full research study to show that the impact that using these UVC towers had on the infection control within the Children's Hospital. And we are part of a very, very large NHS trust, and there is currently 7 hospitals within our trust, 5 of which are all on one site. So for just one of those hospitals to go and do a piece of work like this, it's quite significant, and the impact that it can have on the rest of the hospitals can be quite significant as well. Hence why they wanted the research to be done. So we did do the research. That was an eye-opener on its own. So if you can imagine yourself in a children's hospital, it's all nice, it's full of little children, you know, and everybody's there, all smiley faces and lovely pictures everywhere. We went in and we did a lot of swabbing in the areas. One of the biggest things that came back from it that surprised all of us was where the most contaminants were actually found. And if I explain to you that we have 4-bedded bays, single bays, parent rooms where they can, you know, have a coffee and things, playrooms, bathrooms, toilets, just the same as every other ward, clinical areas. All these areas were swabbed. And can anybody guess where the most contaminants are actually found? Remembering this is an oncology unit as well. No? Well, believe it or not, it was in the parent room. We found every bug that you would expect to find in a very, very dirty place in that room. But this is also the room, remembering these are oncology children whose appetites are not the best, the children, so they can be a bit fussy about what they eat. Parents were bringing in food from outside, storing them in this parent room in the fridge, then preparing them on the sides in this room. We found E. coli and all sorts on the work surfaces. That was the highest contaminant we'd found in that room. Now, this isn't a room where you would normally go in and do a deep clean. Right? It's not something that would be on the radar for deep cleans, you know, because there's no infected patients in there as such. It just showed to us, actually, that what we're considering is clean areas and not necessarily clean areas. Clinical rooms where we're preparing drugs, dressings, things like that. You know, we found contaminants in there as well. And yes, they do get deep cleaned, but we still found organisms in there that shouldn't be in there. So part of the research was that we swabbed lots and lots of different areas. We then did it so that we did pre-clean with the soap and water, and then we also did post-clean as well. And we compared the results from where we just used soap and water and where we'd actually put the UVC towers in and used them as well. That research actually showed comparatively the same as what our pilot study had showed. I think in reality, and Val will correct me if I'm wrong, it was something like where Surfacide had been used, there was a 86% decrease in the bacteria, in the contaminant counts post-Surfacide in comparison to 63% where just soap and water had been used. So based on that, we decided to continue with the pilot, or the trial, whichever you want to call it. We decided to continue with that to see whether we could actually get to 12 months and then 2 years and do another comparison study. And as I said before, we're just coming to the end of our 2 years now. The general feeling is we've reduced our infection control quite considerably. And one of the ways for us to see this is previously if we have an outbreak, so that's more than 2 acquisitions on any one ward of the same strain, we would class that as an outbreak. In those cases, we would have to get a system in to come and decontaminate the either rooms or the ward areas. And the standard that we use at our hospital is the deprox process, which is a hydrogen peroxide vapour. For us to use that, we have to close the ward or a particular area down for anything up to 6 hours. Obviously, for the gases to be to decontaminate the room, and then obviously for the room to be safe to use again afterwards could take up to 6 hours. That has massive impacts on our beds. We haven't had to use that device now for nearly 2 years since we introduced the UVC. So just from that point of view, we know that we've made some impact on that. That's also had a massive cost impact on the hospital. Our wards, with the size that they are, it costs on average around about £36,000 a time to get the deprox machines in. So even if we've just saved 2 deprox initiations, that's quite a considerable amount of money to save in a year. We want to continue using these products that we've got at the moment. And as I said, we've completed the research. It's hopefully going to be published later on this year. We've done the mixed room testing. We've got the data from that. That will also be in the research that we'll be showing. And we're coming to places like this to tell people about what we've done. It's quite an innovative approach that we've taken, and we hope that people will take from today, first and foremost, what you currently do doesn't necessarily mean that's how you have to do it forever in a day. You can look at different ways of doing things, make your own findings, do your own research, find out whether there is something better out there. Because nobody goes to work purposely to harm any patient that they have. But we all have it in us to be able to look outside the box and look at new things and new ways of doing things. And that's what the staff at the Royal Manchester Children's Hospital have done. So just on the slide there, you can actually see what the research was, because I wasn't sure of the figures. And it said that a large proportion of UV sites, there was an 83.7% versus 67% decrease in the contaminants that were found, which is a really significant finding.
Well, thank you, Julie. We're happy we could collaborate here in the UK and with the NHS at Royal Manchester. And thank you, too, to Val Edward-Jones, who, if we do have specific questions, we can pull Val in. Val is the microbiologist within the NHS who carried out a lot of the studies and the data. So what I'm going to do is focus a little bit more on the technology, a little bit more broadly. We'll step back and talk about UVC and a little bit even more about our approach to UVC. We're one of the latecomers. We observed a lot of what the first generation single emitters had done, and we got to preferentially select what we thought would be superior in the design and delivery of a more advanced system. So we'll talk about where we've gone, how our system operates, how we overcome some of the challenges with UV, and I'll review very quickly a lot of the data we've accumulated from around the world and show you a little bit about our most common applications. Well, in the UK, it's still very widely underpenetrated in parts of the world, in particular the USA. A lot of hospitals have gone to using UV as an adjunct to their manual cleaning. And even if I followed John Otter's blog regularly and enjoy that, you'll see recently he said it's time to go shopping for UV here in the UK. One of the challenges is obviously the constraint on resources. So we require proof and the burden of proof and evidence, and I'll try and share some of that. We try and focus on what does the literature tell us, what is the actual documented evidence and outcome of our actual therapy, and how can we compare those two to make a good educated choice. So the way that we've designed our system differently is to overcome the challenges of shadows, of distance, and then to your question about how do you efficiently deploy this. The cost of labor can often in the long run overcome the cost of the technology. And so what we've done is we've combined 3 emitters into a single system. Principally, that accomplishes 3 things for us. First, we can overcome line-of-sight challenges that single emitters face. They're simply, UVC is a line-of-sight technology that must deliver and be exposed to the surfaces to have any efficacy at all. Second, what we do is we overcome the distance challenge. Because of the physics and the laws of physics, being closer in proximity to those surfaces means the intensity is greater, which also then shortens the time for the duration of that disinfection cycle. And lastly, we can do a single set it and go approach, where a single emitter is going to require a housekeeping or a nurse or another staff to make multiple positions. And there's all kinds of wild claims about how quick somebody can kill C. diff. What we like to do is deliver energy to the adequacy that it takes to be efficacious and completely germicidal in one easy set it, go, push start, and you're done. You move the equipment to the next space and you move on. So our 3 emitters are a single cycle. We also combine and use a lot of technology to automate that cycle. One is laser validation. We're measuring the space and the dimensions, and we're adjusting the cycle time with our calculated algorithm so that the exposure is greater in a larger room, shorter in a smaller space. We also have the ability to do timed cycles and user-selected cycles. We also have a targeted disinfection, and later I'll show you how we can do that, which is very applicable to the UK market and we're using regularly at Royal Manchester, which allows the user to choose a selected start point, end point, and rather than spinning and rotating to do whole room disinfection, we're just targeting the area and we're scrubbing with energy over that space. So, shadows, distance, labor, but our ultimate goal is to partner with you, and we can't claim that UV is a magic bullet. There is no such silver bullet. It's combined with good adjunctive manual cleaning. It's combined with all the other things we've heard much talked about even this morning. But what we can do is show that we do make a difference. And that difference is come out of an experience over the last 2.5 years. We've been installed in about 180 hospitals in the U.S. We're one of the fastest growing solutions within the UVC space. And what we've been able to do, while this is a little bit of a brag board, it's more designed to say we choose to collaborate and learn and understand what were the challenges in implementing, what challenges do you face here in your market, and we learn from that and incorporate that to evolve to the next solution. We can share some of our quick data, and I'm not going to focus on these. Really, this is just an environmental kill, a comparative, the blue bars showing post-manual cleaning, what were the CFU colony counts on the key high-touch surfaces, and then we ran a UVC cycle, and you'll see represented in the red bars the logarithmic reduction, typically a 3.5 to 4.5 log reduction or greater. While I do advocate, and our recommended approach is obviously as a follow-up to manual cleaning, one of our primary alpha sites wanted to test the limits. And one of the limits to UV is the line of sight. So if there is a veneer or a high load of debris, we cannot penetrate underneath that. So the greater the manual cleaning, the more efficacious UVC will be. But even absent cleaning, you can see the significant reduction on even C. diff spore. C. diff spore, because of its physical composition, is one of the highest resistance organisms to UVC energy. So it takes a greater amount of dosage to be efficacious in its germicidal effect. We also have some clinical outcome studies where one of the worst hospitals in the state of New York in the National Health Safety Network reporting demonstrated in their first year of use with Surfacide a 41% reduction in C. diff. We also have data that show about some of our reductions in some of the newly emerging superbugs, including the MERS, where after just a 5-minute cycle, we found that the MERS virus was extremely susceptible to UVC energy. We talked about CAUTI rates. This comes from a large teaching institution in Jersey where in their medical ICU, they did a 3-month trial after a real bout of CAUTIs. During those 3 months of use of Surfacide, they had 0 infections. Their infection control team actually was so excited, they started pulling it around throughout the remainder of the hospital, and when they strayed from their strict protocols and use in the MICU, the infections came right back. They brought it back and used, it's true kind of crossover study, used it routinely then, and they went again another consecutive 4 months without a CAUTI in the MICU. We've been used a lot in burn units. We've been used a lot in ORs. We've been used a lot here within the UK. We've principally been used at Royal Manchester, but we also have been compared to some of the other single emitter technologies and our effect on C. diff and others with Prof. Wilson. And you'll see one of the things that we just saw again out of Dr. Otter, John Otter's study is the tremendous cost of an outbreak. So while the financial business model is difficult, it's taken us a bit to come to a point where we finally have a frameworks agreement within the NHS, but this data and the tremendous cost and the waste and unintended care and consequence cost is hugely significant to help justify UVC. So we could have chosen any of the types or vehicles to generate UV. We specifically chose continuous UVC at a 254 nanometer. And the reason we did that is because of this spectroscopy below, where the germicidal effect is very narrow. While there are broadband systems out there, and there is some minor effect at those edges in the perimeter, the 254 to 256 nanometer spectrum has clearly been demonstrated as most effective. The other reason we did so is we found that while we do have mercury in our lamps, we use a pelletized mercury in an extremely small amount, less than the average fluorescent lamp. And we also have been certified both by the EPA within the CE Union Canadian standards. We're RoHS compliant and ETL registered. Another reason is because of our high efficiency and our long lamp life. Our lamps are as long as 20 times longer than some of the other competitors. So while you may hear uproarious claims about how bad the mercury content in a system is, we chose that and feel that it's actually the most environmentally responsible, and it's high output, long life, and more importantly, its efficacy are really what matters. This happened to be something I found recently just out of the scientific committee, out of the European Commission, where lamps like what we use actually offer a net environmental benefit compared to incandescent and halogen light bulbs, even when mercury content is taken into account. So make sure you look at the facts and seek those out. The other thing that really matters about a UVC system is the amount of energy that can be delivered. And our first data, actually going back 4 or 5 years prior to commercial release, demonstrated that C. diff spore required far more energy than had been previously published in the literature. To get to a significant logarithmic reduction, it takes tremendous load. Total delivered energy directly correlates to logarithmic reduction. Let me talk about shadows a little bit. We mentioned it before. On the left, you'll see how our multiple emitter approach will continuously and with one setup cover the whole room. And whether you run it for 10 or 20 or 25 from each position, the inefficiency and the downtime, as well as the total energy time, to get equivalent to one 20-minute cycle of all three of ours, you'd need to run 3 20-minute cycles with one emitter, and you have the labor requirement and the inefficiency. Also, what's become more and more important is the reporting capability and the validation. So while we would run one continuous cycle and bump all that data into the cloud, it would show as one cycle, where with a single emitter technology in that same room, that would be reported as 3 cycles, which becomes more important as you're correlating and studying and proving the efficacy of technology. The distance we talked about earlier, but let me show you how distance plays out as it relates to UVC. As the energy travels in a straight line, as that distance doubles, the intensity isn't merely cut in half, but it's the inverse of the square. So as you get to longer distances, the time requirement goes up so greatly, it takes a tremendous amount of time to deliver adequate energy. One of the other ways we help to expand that energy and concentrate it is by our design and our parabolic concentration, so that we have zero energy loss and we're directing a highly concentrated beam of UV on all surfaces. I mentioned our laser validation. This can be a portion of the cycle where you can actually measure and take an array, and the algorithm will calculate the length of that cycle. One of the potential downfalls of our approach is having 3 emitters could mean that it would be hard to move 3 emitters. And while I will admit we do take up a greater footprint than any of the single emitters, it's the ultimate efficacy. And what we've done is we've designed it and won some Smithsonian Institute of Design and other design awards about our innovative movement and portability. It takes about 10 to 15 pounds of ergonomic force to easily roll. The components of our system will automatically or actually help you decouple, and we reutilize those as either a tablet holder or as a safety sensor inside the room, and then they recouple for ease of movement throughout the hospital. So quickly as I conclude, where have we been used? There's almost no space in a hospital we have not been used at. The most common is those rooms with contact precautions. We're also just routine discharge at many of our centers. The triple emitter approach is great for larger spaces. One of the other things it allows us to do is to decouple a single system and take one tablet, one emitter, and we can actually do 3 bathrooms simultaneously by decoupling the triple emitter into 3 single emitter systems. And the daily clean of especially C. diff has shown to have tremendous promise. Operating theaters are commonly done, multi-bedded bays. And one of the things I want to show you is how we're able to accomplish uniquely multi-bedded bays. Because of our parabolic concentrator and because of our laser alignment capabilities, the user selects with the laser a start point A and an endpoint B. And rather than the towers rotating circumferentially the entire time, what they'll do is merely oscillate back and forth between those two fixed spaces. That's perfect for within a multi-bedded bay where there may just be a privacy curtain, because as you can see on this animation, no energy is directed rearward or towards the staff or the surrounding patients. So it's safe to use, and it still very much concentrates that delivery of UV where the patient area and the equipment is. Reporting I mentioned, we've just overhauled our entire dashboard and all of our remote reporting that's in the cloud. But our goal was really to put the power of all this information at the user and administrator fingertips so that you can create your reports. It will automatically schedule how you want the information and validate what your team has done. We're happy to follow up with you here or through our Global Training Center. We have simulators that can help us create spaces like what you face and show you how our equipment can work there. We are a UK or a US company. I live in the Midwest, but we're happy to be in the UK.